Quick disclaimer, all information, content, and material of this podcast are the opinions of the speakers and is for the informational purpose only and not intended to serve as a substitute for the consultation, diagnosis, and/or medical treatment of a qualified healthcare provider.
Welcome to the Untethered podcast. I'm your host, Hallie Balkin. I'm a certified orofacial myologist, feeding specialist, SLP, and mentor. This podcast is all about getting your questions answered and collaborating with colleagues to bring you the most up-to-date information in the orofacial myofunctional therapy, tethered oral tissue, and airway space. I challenge you to keep an open mind and join my mission to get this information out to the masses. Let's get started.
Hi, and welcome to episode 55 of the Untethered podcast. Today we have Dr. Kimberly Baer joining us. Kim was born and raised in Maryland and went to College Park at the University of Maryland, receiving a degree in biology. She then went on to the University of Maryland's dental school and received her doctorate in dental surgery in 1999. She completed a master program at NYU in implantology in 2001, and she followed this with a mastership in orthodontics with the American Academy of Orthodontics. In 2007, she did a master's program in biological medicine and toxicology, and during this program, she completed a board certification in naturopathic medicine. This has been followed up by millions of classes and certification programs, which I can vouch for because both her and her partner, Dr. Kip Tippegraph, are CEU junkies like myself, and she is also a fellow of the IAOMT.
Kim, thank you so much for being on the podcast today. Obviously, I'm super excited to have you here since we personally work together and treat some cases together. So welcome.
Hallie, thank you. Love working with you too. It's really changed the way we actually work. So this is an honor. Thank you.
Thank you. So let's just dive right on into talk about how you fell in love with treating airway from a dental perspective. And then, also share your journey because I know you've had your own experience as a patient.
So I graduated from dental school in 1999 and I had lots of sleep issues and that were passed off probably as depression and narcolepsy and different things like that. And lots of jaw, neck issues, all that stuff. I didn't put it together with Airway. And then in 2007, I was starting my mastership program with the American Academy of Orthodontics. And I had, at the time, my son was 7 years old, and we were having terrible issues with him. He was in an isolated classroom. They couldn't figure out what was wrong with him. It was like, almost like temper tantrums, but rage. And no one could figure out what was wrong with him. And we were told that he'd probably have to be institutionalized. So anyways, so of course I started this mastership program, hoping for a little distraction in Baltimore. And they're very big. This academy is very big on airway, which I really had no training on. And the very first day, the very first lecture by Chris Baker in Baltimore, she did it all on airway with children, and she threw up these slides and showed skeletal things and what their mouth would look like, what their tongue would look like. And I sat there, and then she described how she sees these kids and they're propped up on a million meds and they've got diagnosis like ADD, ADHD, bipolar, things like that. And really what they have is most of them have severe sleep apnea. They are living oxygen deprived. And she described skeletally my son to a T. And I just sat there and I drove home and it was like, oh my God, I got to get a digital CT. I know what's wrong with them. And I got one that week and I took it and she was dead on. And then I found the youngest, most progressive ENT I could find who's no longer practicing in the area, sad to say. And I didn't say anything to him. And I brought my son in the following week. And I said, I want you to do an evaluation on his tonsils and adenoids, because I was told they did not need to be removed by ENTs, his pediatrician. He was never sick. And the guy took a look down his throat, and I showed him my CT scan, and he laughed. He's like, I never see this when they come in. But he was like, I don't want to get your hopes up, but I don't think your son's going to need any medications when I'm done with him. He has severe sleep apnea, no doubt. He's not getting enough air. He feels like as if you and I would feel if we'd been up for 48 hours straight working. And this is all he has known. So you take an immature kid who doesn't know he's tired, he can't tell you he's tired, it's going to come up as hyper or lethargic, moody, all these things. And we had his tonsils and adenoids removed as soon as we could. It was maybe 6 weeks later. And then he went from being one of the most highly medicated 7-year-olds at NIH to basically almost off all his meds within 6 months. Now, this is an extreme story, and he went from being in an isolated classroom with a bunch of dangerous children to being in a GTLD program the following year. His diagnosis was from bipolar to maybe a little Asperger's. So now my son is finishing up his freshman year in college, and he's a different person. But that made me just opened up my eyes to the whole Airway thing. And then, I started doing ALFs with that academy, and I do everything. We do the DNA. It just depends on the person. The DNA, there's all kinds of different appliances. I have some kids who are super non-compliant because, you got an airway issue. Let's say you're a little ADD, they're usually very sensitive orally. They can't, they have all kinds of proprioceptive issues going on. And sometimes you just can't keep that ALF in their mouth. So I will put them in like a rapid expander, cemented in, for usually about 6 months and get the width we need, which increases the oxygen pretty quickly. It's not ideal skeletally, but at this point, you got to choose the lesser evil, and then I'll usually switch them over. They're much more compliant at that point to the ALF or whatever we decide. But it's a journey depending on the kid. And the craziest thing is, and I was little, I did some myo training, and I remember I worked with Dr. Jennifer Tipograph, and she really brought you in, Hallie. And she was like, I want all my expansion cases and going to see the myofunction. That's been crazy, seeing the difference in patients that work with you or work with another therapist, and then the outcome. You see, first of all, the results are always better and faster. So it's been really, really cool seeing what a huge difference. And you guys really, I always tell my patients, it's very interesting because if you have an airway issue and you go see, you guys said there's a finish line with the treatment you do. Like, they do the work. It doesn't take that long to see the results. It's crazy.
Yeah.
So, I tell my patients, you're investing this time and this money. Like, you can get great results or we can do as good as we can without her. But, why would you, and when they put it like that, patients are like, yeah, so, yeah. So I think what you guys are doing is a huge part of it. But then, I really didn't dive in so much into the adult aspect of it for a few years. And then when I turned 40, which was a little while ago,
Okay, you still look like you're 30.
It was 10 years ago. So 10 years ago, my daughter, who was sleeping with me sometimes, she had a nightmare or whatever, she would say, Mommy, you're snoring. And I was like, no way I am snoring. Then I had to stop and take a look at myself and my airway. Sure enough, upper airway resistance, and I don't know if people understand the difference between the upper airway resistance and sleep apnea. You don't have to stop sleeping at night. If you're snoring, there's something in the way that equals less oxygen. Is it worse or better than sleep apnea? Not necessarily either. You can have upper airway resistance in a manner that it's just decreased oxygen all night long. And that's what I was having. And that's what I always had. And it's so interesting because my son, I should have learned, right? All of a sudden, I did an alpha myself first for the first year. I was pretty small. And then I moved on to a DNA, and I like to make all the mistakes first, then before I treat my patients with the items. And then I saw it was just huge. All of a sudden, I could come in to work and I wasn't exhausted. My staff noticed, there was nothing wrong with me. I wasn't depressed. I was tired. You know what's depressing? Being tired. That's depressing. It's like this crazy, it was a total misdiagnosis on, in dental school. I was just exhausted. I was exhausted because my quality of sleep was nothing. And, and I know this, but when we have patients coming in, it's crazy because you see it. I see it more so than I don't see it. So someone can come in and I can look at their jaw, I can look in their mouth, and I know what's going on there. And you have to hold back, because otherwise you start to sound a little crazy. Everybody needs to be expanded and everybody needs a frenectomy. But the truth is probably most of us do in this country.
Genetics, things are changing, and it's just...
It is. And, but it's not sometimes it can be the right treatment, wrong time. Everybody's got a journey, and there's a certain, earlier better. But we do work with 70-year-olds, expanding them and opening their airway, and get great results. It's just a matter of what chronic issues, have been developing for all these years. For instance, everyone in my family dies of cancer. So cancer, what does cancer love? A low oxygenated situation. So, hopefully I'll at least buy a few extra years.
I mean, that's amazing. And thank you for sharing your story and your son's story, because I think you're going to help a lot of moms who listen to this podcast, parents, fathers, who might go, holy cow, that's my kid. Or maybe it's not that extreme, but they see certain, things they can relate to in how their child just seems to be acting out all the time, or walking around, or maybe they're the kid who sits backwards at circle time in preschool, or maybe they're the kid who can't sit still and needs to lay on the floor at their elementary school to do their schoolwork, or they come home and they just melt down because they've used they've expended all their energy at school and they have nothing left by the time they get home at 3 p.m. And these are more extreme cases than your typical child who might just be tired. This is, it's not tired from the day of school. It's tired because, like you said, they're constantly in this state of fatigue and they don't know anything different. They are not getting restful sleep. And that's what I always try to explain to our patients is there's a difference between a child who sleeps 12 hours straight and doesn't wake you, and they're actually sleeping and getting restful sleep, and the child who's sleeping 12 hours at night who doesn't wake you, and you have no clue that there's upper airway resistance, even if sleep apnea is not present. They may not be gasping for air, they may not be snoring, but maybe you can hear them breathing still. Maybe their mouth is open and it's audible breathing, or their mouth is just open and maybe we don't hear them, but they're still mouth breathing. There's generally some form of resistance. And I listened to a really great talk on this yesterday that was really highlighting this too. And I think it's a really big message because so many people, one, don't know that snoring is not normal. And I put things up on social media saying snoring is never normal, but neither is mouth breathing. Your mouth should always be closed. And so I think I'm starting to drive that message home because I asked on Instagram yesterday, I'm what is the number one thing you've learned from me? And people responded, they said, no snoring, your mouth should be closed. I was oh, thank goodness, the message is getting through.
That's huge. And if you can't do that, there's a problem. Yeah. Right.
And hopefully they understand who to seek out. Or, I've been really, with the platform I have, I get a lot of people asking me, well, who should I see? Do you know anybody in this area? And I can often go back to a Facebook group or a listserv and be hey guys, I need a practitioner here, and connect people. And while it's very time consuming, I'm happy to do it, because if I can help somebody get started on their journey and, to better health, better airway, and all the things we're talking about, then I feel that's the whole point of this podcast. So, it's really exciting to see that people are getting the message. And, airway is, I always say, airway is everything. If you can't breathe, you're dead.
Air and water, you can't, no one, everyone feels better if you get more air.
And you're hydrated too. Yeah.
No, it's so true.
Now, you also talked about how you use various appliances in your practice. Can you speak a little bit to that? Because I know we've, on some of our shared patients, obviously I've done ALF. I think we've had some go into AGA. We've had mRNA, DNA. I know you mentioned rapid palatal. I don't think I've had any kiddos with you yet that have had RPE, but I think all the others, I've had patients that have had one of those four, or a combination or something, based on your case.
Yeah. So, I mean, there's probably, I've been doing expansion for about 13 years. So there's very few appliances I don't use. I have not tried. Always up for trying something different. Ideally the ALF, I love with kids. You can use the DNA on kids. It's just, it's tricky because, they're losing teeth and it's not as, you don't have as much control. They don't keep it in all the time. So, it just depends on the case. But I have some kids I've, put removables in. It also depends on, the parent, what the parent can do. A lot of parents cannot have the time or the energy to, deal with that. But I have a lot of patients, I start on an ALF and then they get older in their teens and we move to the DNA. I love all these appliances. We're not, the Vivos community, which is the DNA community, they bought the DNA out. It's a great organization. We work with them a lot. We're not members per se, but it's only because even though I love everybody there and, they're doing amazing work, in our practice, we don't commit to one appliance. So, it just depends on the situation. Some kids, and adults, I have a lot of adults that come in, they want something fixed in their mouth. These are small appliances you can't see. Some adults don't want to deal with, having to put something in and out of their mouth at night. And it's very interesting because, especially with my adult patients, it always seems a little overwhelming to make this commitment for the expansion, but it becomes an addiction. And I struggle cutting people off from treatment. Every day I have a patient where I'm like, okay, we started this 1-year treatment 3 years ago. I think we can stop now, because they feel so good, which I like. But yeah,
Dr.
These are the ones that were like, I don't know if I can do this. I don't know if I can do this. And I'm like, well, I don't know if you can you do this? I can't wait to get how important is it to you to make these changes? And 9 out of 10, they do it and they love it. So
yeah, well, I'm laughing because, Jen asked me, Dr. Tipograph asked me, she's like, so, what do you think? What do you think about the space up there now? Do you think we're done? And I'm like, well, what do you think? So she's like, well, I think we're getting there. We're pretty good. And I was like, I don't think we're done yet because the back of my tongue still touches my back molars and there's like some more space back there. And she was like, okay. But I was like, oh gosh, I'm that patient where it was like, I'll probably have you in this for a year and, maybe a year and a half. We'll see how fast you move. I mean, I also know that I hit a wall unless I have body work. And that happened about halfway through my treatment. I was moving. I could crank it. And then halfway through, we realized that my maxilla is turned in on one side. Manny realized that. And we had thought that there was other misalignment in my mandible. And we realized, nope, it's the maxilla. He looked at me and he's like, wait, no, your mandible's aligned. It's your maxilla. And so I'm like, look, my incisors, my central incisors don't match up on top and bottom. And so I said, I don't really want to stop until we can figure this out. And I don't want to break my jaw either, Manny, so fix me. So we're working on that. But I also noticed halfway through that if I do the body work, right, I see Manny for the physical therapy, the modern counter strain technique that he uses, I'm then able to adjust my appliance again. Whereas the day prior to seeing him, I could no longer crank the appliance. It didn't matter what I did, nothing was shifting or moving. And then I would get treated by him. And then all of a sudden everything's moving again. And I can now continue on with the appliance work. So I've also been seeing him in between my dental appointments to try and help that go a bit further. And I think my expansion now is where I want it, but I want to make sure that before we pull the DNA out, my maxilla is where we want it to.
Yeah, you can't, anyone who thinks that you can do the expansion without, the body work, the IPR or the manipulation, this is the top of the zipper. And as you go down, if you're a little off, it just gets worse. So you can do the expansion without the tongue, myotherapy and the structural therapy, like with Manny Kim or Louise Kelly, who's amazing, IPR, but you will never get the results. And that is why we brought them into our office, because I had an issue right after I started expanding myself. I started running marathons. It was a bucket list thing. I never ran a marathon before. Anyways, I qualified for Boston. I was so pumped. It was my second marathon. And 6 weeks before, I had this knee issue, and I saw an orthopedic surgeon. He did a shot, and he was just like, with these issues, you're going to be off. You can't run for a year. You're done. And I was like, no. And so it was like 10 years. So I saw a friend of mine refer me to Louise Kelly, who was, her and Manny used to work together. And that's how I met Manny Kim, Dr. Manny Kim. And she did some dry needling, and then she did some structural evaluation. And she basically took these sticks and said, and I could not walk without pain. I was in so much pain. And she taped them together, and she was like, your skull is off kilter. I was expanding myself. I wasn't getting structural work. She's like, so when she stacked them up to like a certain distance and put them on the right side of my mouth, she was like, now get up and walk. And I'm biting on them, which evened me out, and my knee didn't hurt. And I was like, that's crazy. She was like, I want you to get back to your office and make your guard that thickness on that side, and then try running with it. And so I did it. 4 days later, with the guard in there, the lower guard, I was running no pain. Wow. I ran that marathon, and I've ran one every year since, and I never had any knee surgery. And so then I altered my bite to like even out my skull. We did some work, and let me tell you, I was like, oh my God, this is like voodoo crazy. Like, how many people are having surgeries and like fixing muscles and bones and doing all this stuff when it's all here? Like, and how many of my patients am I expanding? Like, how do I know, like, I'm making this bigger, but if they've got something else going on, how do I know, it's not affecting their ankle or their knee? And they're not going to put it together, but now that I know, I can't go back. So then I was like, I need to figure out a way to bring you guys into my office. And I had no idea how I was going to do that. So I brought Louise Kelly in on Tuesdays and Dr. Manny Kim on Thursdays. And this was 7 years ago. And we just pay them to come in for the day. And I was just randomly had patients on my schedule. I was like, oh, I bet they have something structurally wrong. And I would just have them not charge my patients and do an evaluation on them, because they would say, oh, you're going to do this crown, or you're going to do this expansion. They were like, you really need to, open the bite up on this side, or do this or that. And they're like, and that would fix their ankle. And I'm like, okay, I look like a genius. Okay, I'm just going to make a crown anyways, but they're going to tell me how to fix it. And then I was like, they're very big on the expansion in the airway. And then we had them seeing every patient we were seeing, and the results were just phenomenal. And it's a no-brainer. Like, like you said, with you, I mean, I'm a dentist, and I know this, and I've learned a lot of other things, but this is what I'm supposed to be focusing on. So, we're so fortunate to live in a place with such smart people. I mean,
it makes it easy to have a team approach when you have people who get it here. I always joke, I'm like, I've got my amazing team. We've got all the puzzle pieces. We're just missing one. We need that ENT locally who really is truly airway centric and gets it. Because, we have some great ENTs that we can refer to. And if we have like blatantly obvious sleep apnea, they're going to take those tonsils and adenoids out. But if I send a kiddo usually, and I say, I have like concerns about upper airway resistance, or I say, please check the tonsils and adenoids. Oftentimes the families get sent away, and then I look like an idiot for wasting that parent's time going to that appointment. It's one of those things where I feel like we've got some practitioners locally, but I don't know that anybody's really, and maybe somebody, maybe you're working with somebody that I'm not familiar with, and we need to talk about that. So tell me if I'm wrong, but I have not been able to find anybody.
I don't know of anyone in particular, but I do know my patients that I send off to the ENT, I will send a report and say that they're structurally, they need the surgery for structural growth reasons. Mm-hmm. And they're more apt to do that with like a CT scan and a report saying, because then it kind of holds them Like they don't, and then things get worse. They're actually responsible. So yeah, you could try that.
And we'll just send them through you. We're gonna send them. We're gonna go see Natural Dental Associates.
Well, we can show them if we can show them an X-ray or scan.
Yeah.
Clearly, and we have an Airway interpretation on the scan now, and it will say too small.
Yeah,
too small.
That's awesome.
It's growing narrow. We need to widen them out.
Beautiful. I love that, because you can't argue with like documentation that, with pictures, right?
No, when you see it, it's hard. It's hard to argue with it when you can see the problem.
Yeah.
I think that's like that for all of us, though.
Yeah, definitely. 100%. That's what I tell my patients all the time. And that's why I take so many photos and videos, so I can show them and I can explain to them and say, do you see that? Do you see how the jaw just moved this way? We don't want that to happen. It should stay over here. And did you see how the tongue and the jaw move together? They should be, working independently of each other. And when we tried to teach it, they couldn't do it. And so I think when we can show parents like what we're seeing as well as practitioners, whether it's through our reports or when I sit down with my parents and I show them the videos and kind of talk through it and explain why we want it to be, a certain way, it's really powerful. I always say pictures don't lie. So
Hallie, how many adults would you say that you work with? I know you primarily work with children.
So I'm primarily pediatric. And right now my caseload is much smaller just given the pandemic. But I've probably worked with less than 100 adults total, but I have to say that my adults are some of my favorite because they move through the program, the MIO program, just much quicker. Obviously, it's from a cognitive level, they're able to grasp what we're asking them to do much faster than, like, let's say a 5-year-old. My teens also move through pretty quickly as well, but my adults are really fun because they're able to really grasp it, kind of like run with it, and I feel like if they don't get something and they need to work on something a little bit longer, we'll give them an extra week to do it. We won't meet, we'll do like 2 weeks between our sessions. And sometimes I'm done seeing them in 5 sessions total. Like it just depends on the person. Sometimes if they're not compliant, it could take longer, but my compliant ones could be in and out in like 5-6 sessions easily.
Yeah. I think the adult tongue tie thing is just it's like that's becoming my new like focus, because for me that was like the last piece of the puzzle as far as like neck tension and sternum issues. That muscle is so crazy. No one thinks that it wraps around your neck and your jaws, and it's just and most of us are airway issued patients, and the tongue is like, that's part of the problem if it's being held down. So like my kids had no problem latching or, they didn't have any obvious speech impediments, but they are all tongue tied. And when you see it as an adult, like my son's starting to get neck issues. We expanded his airway, but we didn't untie his tongue. So we're getting ready to do that. He's older now, so it's a little bit of a fight, but we'll get done this summer.
Well, and so this is a great question because we get this a lot, right? I have parents who will bring their babies to me for an assessment. So they're like, okay, well, you do a ton of infant tongue ties, right? Like that's kind of like my little love is the babies. But they'll say, well, they're nursing okay, they're transitioning to solids, like they're hitting their developmental milestones. And so I'll tell them, it's not a tongue tie unless there are symptoms, right? If they're asymptomatic, like it's not a tongue tie. However, we need to monitor for like these things coming down the road. We need to pay attention to posture. We need to pay attention to airway. We need to pay attention to sleep. We'll run them through the gamut of like all the things that you need to be aware of, like all the red flags. And sometimes they might come back a couple of years later. And so, as a practitioner, I sit here and I go, well, I know it's not a tongue tie, but do we intervene now because we know that there's going to be issues down the road, or do we wait till the first symptom happens?
You do it. I think you intervene.
Yeah.
You can ask the parent, like, why, reflux, heartburn, it's all this, and if they're having problems, if it's tied, they're going to have, the airway, especially as they get older, once your testosterone levels start to drop, like especially with women, like late 30s, your soft tissue, your airway gets smaller.
Yeah.
It doesn't, I'm a huge fan of bioidentical hormones, by the way. I'll do a plug there because that really helps with that. But your airways just get smaller, and then you're just getting less and less air, and it really makes you think about aging. Like, aging is aging. We've already, like, people are aging better now than our parents' generation, but how much of aging is really due to chronic decreased oxygen levels. If you were to take somebody and they got the same oxygen they were getting when their airway was big and open at 20 throughout their life, how would they age? Because that's a huge part of it.
Yeah.
That's
a really cool question.
With most Americans at a certain age, especially in their 70s, are going to have, sleep disorders. They didn't have that. Like, you have like dementia. It affects dementia, Alzheimer's, cancer. I mean, cancer loves a low oxygenated environment. I mean, if you were to eliminate that, not to say that none of these things would still happen, but what would the numbers be? What a cool study that would be.
Yeah, that's fascinating. Yeah, and it's, and you mentioned like a number of the symptoms when it comes to tongue tie, and in my 30s is when I realized I was, I'm still in my 30s, but I realized I was tongue tied, and like about 5 years ago. And my mom said to me, well, yeah, your aunt, who's a speech pathologist locally, she's like, well, she said you were like the floppiest baby she'd ever seen. And I'm like, great, thanks guys. Like, are we talking about like, Ehlers-Danlos syndrome here? Like, are we talking, like, I've now worked with a physical therapist who's like, I think you have ADS. I'm like, great. This is probably why I've like never been able to get like a really strong core, like no matter how hard I worked, even when I was like a like tight size 2, doing like insanity workouts and P90X, like still like the hardest thing for me to ever get in shape, no matter how tiny I got, was like still like my core. And I'm like, this just makes so much sense. But I also was tongue tied and had sleep disorder breathing, didn't know any of that. It's interesting because well, not interesting, but couldn't breastfeed. They put me on all kinds of alternative formulas. They thought I couldn't drink the milk, and I had a milk allergy. And so my mom's like, you refuse to drink the soy formulas because back in the 80s, they smelled like dirty socks. She was like, this is like my history. This is how my mother reports my infant history.
They did smell like dirty socks.
Right, dirty socks and then super floppy. I'm like, great, that really sticks in your brain. And then so I get through school, I get like good grades all through school, I go to college, and all of a sudden things just fall apart. Like, I practically flunked, not really, like I got passing grades, but for me it was like flunking my first semester of college. I was like, what the heck? Like, I'm doing everything I've always done. I went from being like an A student to being like a C student. Like, what is this all about? And I would go back, and I actually went back to a test that I got a C on in the business. I went into the business school, into the classes, and then ended up switching, obviously. But I was like, I know 13 of the 15 answers I got wrong. 2 weeks after the test, I haven't studied or picked up the material since. Like, what the heck? And I just started to realize that, like, it was probably my sleep disorder breathing. Like, I could not focus when I was taking tests, especially in a large classroom with like an auditorium size, with like, every time someone would like, take a pen and like do this, I was like, what, like, there went my attention. And so I was highly inattentive, couldn't focus, and exhausted, I'm sure, because what do you do in college? You party and then you study the night before your exam. So that's what I was clearly doing. So anyways, my parents had me go get tested for ADHD. And the backstory on that is that when I was 5 or 4 or so, and I was in like preschool, going into kindergarten, all the teachers said I had ADD, and my mom refused to believe it. She said she's like, I called one doctor before they ever met you. They diagnosed you over the phone. I called another one, and they brought me in and met with me, but hadn't met with you and diagnosed you without meeting you. And then I took you to a third one who kind of like was like, well, I don't know. And so I went with that person. and she was like, I just refused to medicate you because they didn't think you needed it. And I was like, okay, well, that's, neither here nor there. I ended up doing okay, but I was also a child who was like angry a lot. Like, I had temper issues, and I would call my mom mean names and tell her she like, it was not nice. And fast forward to college, right? I go and I get tested as an adult now. And they basically said, well, your IQ is too high, so we're not going to give you a diagnosis of ADHD, but you're a candidate for Ritalin. So here's the medication. You're highly inattentive, and, you know, take it. And it ended up really helping me in college. I hated myself on it, but I took it throughout college, throughout grad school. I went up to like a 3.5 GPA my first semester on it, and then a 4.0 through the rest of college and all the way through grad school. And then as soon as the day I graduated grad school, I was like, I'm done with this stuff. And I stopped taking the medication because I'm like, I actually did a research study on it and was like, there's no longitudinal studies on this. I could be like destroying my body. Like I hate this stuff. I'm done. Even if it really helps me like focus, I'll figure out other ways. In all that, I also behaviorally learned how I needed to study for myself, and I needed to start a week before, and I needed to chunk my study sessions, and I was able to retain information in different ways. But like when it came to actually taking the tests, like the medication really helped me. And now what I later realized was, wow, maybe if somebody had looked at my airway, we could have avoided all of that. And, you know, it's so fascinating as an adult to look at my history because everything is tied into my airway issues.
Yeah, I think that's the American way that we medicate for symptoms instead of treating the problems. And once you start thinking like that, I'm not anti-medication. Like I am a believer that first of all, it's a personal choice. And second of all, once you really start looking at what's the problem, like why is this happening, to fix it correctly, it's not quick. So maybe you need something to get you through a period of time or whatever. It's different for everybody. But in this country, we want a quick fix. I'm guilty of it in many ways. You just gotta be patient. You didn't develop that problem immediately. You're not going to fix it immediately. You know what I mean? And sometimes, yeah, we really like, why, okay, this is really off kilter. Like, for instance, I have a friend who has high blood pressure. Why does he have high blood pressure? He's not overweight. He's ridiculously fit. And I say, so why do you have high blood pressure? Like, if you ask your doctor, he's like, oh, it's genetics. And I'm like, yes, everything is genetics. Why do you have high blood pressure? Now, it's not super high, but your blood pressure should not be high. You probably have like 10% body fat, your cardio, you're in sick shape. Why are you taking this low dose? And then you think, our bodies are amazing. So why does your body need your blood pressure to be high, right? So I eventually talked him into coming into the office. He's a trainer, and I did a CT scan on him, and he has the smallest airway I've ever seen.
Wow.
And to look at him, he's clearly compensating well. But his body, he's getting, let's say you're just getting, you need, let's say, 100 liters of oxygen, and you're only getting 10% of oxygen. Your body is so amazing that it will take that 10% and it will restrict the blood vessels and move it around as fast as it can to try to make it into 100, get it to all the important organs and do all that. So your body's working overtime to move this oxygen around because all it has is this 10% of oxygen, and it's compensating, and it's working well because your heart is strong, you're fit, you're compensating, you're eating well. And then you take a blood pressure medicine that dilates your blood pressure so your blood can't move the oxygen around the same way, right? How is that good? Like, wait a minute, why does he have high blood pressure, number one? Number two, now we just undid what your body needed to do. Mm-hmm. And now diagnosis is ADD. So we're gonna put him on an ADD med with this low, and I'm just like, this is like one of the healthiest people I know. And so he's finally on board with the whole airway thing, but I'm like, I am only a dentist. But I do know when we make these changes in people, like when we fix airways or decrease infections in this area, their blood pressure goes down and they tend to be over-medicated. They tend to not even need their medicine or need to alter the dose. They have to see their doctor. But I was like, you shouldn't need this medicine.
Yeah.
You should, like, why? And I think that that's just a big problem. I mean, people don't even think. They're like, oh no, I need this because I need this, but why?
Well,
why do you need it?
So much trust in our doctors, right? They're doctors. They have MDs after their name, whether they're a general practitioner or a specialist. Like, we go to them for a problem, and they're supposed to know the answers. And I think that, that's American culture. And I think anytime one of us challenges that, they kind of go, wait, whoa, you're not a doctor, or you're not a, and it's like, maybe not, but I can see the results I'm getting from my patients. And I don't really have people challenge me because I'm not typically going against what their doctor says. I'm just trying to provide alternative, which I'm sure you're doing too, is like, we're providing alternative means to figure out the root of the problem rather than slapping a Band-Aid on it. And that's, American culture is slap the Band-Aid on and move along.
Like in the beginning of your podcast, when you make that statement and you're like, open up your mind, it's so true. Because doctors, and they're not the enemy. Like, they can only do so much. I mean, they're seeing you, and their job is to make sure your blood pressure's not high, so your kidneys don't, I get it. Like, you have to take responsibility for yourself. You have to advocate for yourself. And you have to do everything you can do, because that internist cannot fix everything. He cannot. And I know, as being a practitioner, I remember graduating from school and realizing when they gave me that license to write prescriptions, I was like, I remember feeling like I knew nothing, and I think every doctor, and they might not want to admit this, but unless there's something wrong with them, they should feel that way, because you really know the minimum. And I remember realizing I don't know everything. I don't know enough. And honestly, the longer I practice, and I've been practicing over 20 years, I knew less and less. I know less and less, and I will never discount anybody. Now I say, whereas maybe 10 years ago, I say, no, that's not true. Now I say, well, not that I know of, but nothing would surprise me at this point.
Yeah.
And I don't think that that's a bad thing. I think that we can learn from each other. And I think as soon as you stop, and you think, this is how I do it, this is what works, and you start closing out new ideas. It's hard to hear, I mean, even like working with a speech therapist on every patient I'm going to do a tongue tie release on. I mean, that there is an initial response of, do they need that? Do my patients really need that? And then, but you got to be like, okay, maybe they do need that. And then you see, so you don't know till you try. I mean, there's so much information out there, especially right now with the whole crazy pandemic stuff.
Yeah. Oh, yeah. So let's talk about, unaddressed airway issues in COVID-19. Because that's a fun topic. What you have to share with us about that?
The common sense. So I had COVID in February. They were not testing. That was, I wish I had videotaped it. It was, I had it like you would have it. Like, it was like a horrible bronchitis. I had all of it. And I'll tell you, the second week when the cough started, it felt like I had emphysema. So I didn't have a fever anymore. So I felt like I was better. I didn't feel infectious, but I run. So even when I'm sick, if I don't have a fever and I'm not too achy or whatever, I'll go out and I'll jog a few miles. And 'cause even if I have a cough or whatever, it all comes out. I feel so much better afterwards. And I would go try to run a mile or two, and I would on a treadmill because it was cold, and it sounded like I was dying. So I would get through a mile. I just got off and I was like, man, I feel like I have lung cancer. Like, I can't run. I can't get enough air. And I was like, I'm going to wait another week and before I go back to the doctors. And a week later, it was getting much better. So I was fine. But, most of us, and I feel like the news isn't saying this, telling people this, we're only hearing the scary stuff. But for most of us, this virus is just that, like getting bronchitis. It's a horrible virus, like a horrible flu. And you'll be fine for most of us if you get it. But definitely, and I kept thinking, if I had an airway issue and I got this, because you're definitely getting less oxygen, and people just have to not panic. Because I sedate people and I see their airways on a regular basis. And let me tell you, most of us are already not getting a lot of oxygen. And I've seen some really bad cases. And these are people that don't even know, they're not even noticing any problems. So I was like, I have to reminding myself, I can live like this. People live like this for years. I just need to get through the next week or two. So, but I did a little research online, and of course, there's actually, I found some really great articles, and like sleep apnea or airway issues, which, are all the same, decrease oxygen saturation when you're sleeping, because I definitely noticed, you're getting less oxygen when you have this virus. And there's some research they did on Sars, which is very, as far as the lungs go, similar. It's basically almost identical. So COVID and SARS are basically, they consider just coronaviruses, and they're considering it SARS, like this whole thing, they're calling it a corona epidemic, and starting back to when, SARS first came around. And so they have patients who they're seeing, if you had a sleep issue, if you had a breathing issue, you definitely are going to battle this a lot harder. And then also they're seeing people who come through it on the other end, if they didn't have an issue to begin with, because of the scarring and the fibrosis in the lungs that happens. And I felt that. They were ending up, they're saying long-term results are sleep apnea, breathing issues. It probably took me a month or two to be able to take a deep breath really well, not cough. I mean, I was feeling better every day, and now I'm 100%, and I'm running, and it's not a problem. You feel like, just like, I could still run, but I felt like if I took a really big breath, I would cough, But if you listen to, there's some great stuff out there. Some pulmonologists are saying how if you have this virus, I was listening to Dr. Radio the other day, and I can't remember his name, but he was great. And I really liked, because he was like his pulmonologist in New York, and he was saying how one of the problems they're seeing is when people lay down, first of all, you're only using like a third of your lung. Mm-hmm. And if we're not moving around, if you're not doing any cardiac, if you're not really moving, you're using very, very little, like half maybe. So if you're running and stuff, you're using like going to whole other depths. And I think that gives me an advantage, because I do that, and my cell turnover is going to be faster. And he was like, we don't want people laying in bed doing nothing. We want them being as active as they can be. If they can work out, because he's like, that is how your lungs heal. Not being careful and staying in bed, an active recovery. So like if you, to get up, move around, do everything you would normally do, clearly, without infecting anyone else. But
interesting.
Yeah, I mean, it's, but the thing is, moving forward, this herd thing, most of us are going to get this. Most of us are going to get this. They're not going to have a vaccine for a year, So I think that people just need to be aware, especially, how important airway issues and tongue issues. If you have this issue now, it's something you should address, because, this isn't going to be the last virus. And if you don't have a good airway, there's no chronic disease you're going to fight well. I mean, it's just a fact. So I think it's something to think about. And with your kids, for instance, like you said, do you treat it now? I would treat it now. Yes, I would. Give my kid every advantage, especially knowing, what I went through. I mean, I wouldn't wish, that on any parent. I see kids with airway issues that are just amazing kids, and there are no issues, but I still tell those parents, treat this airway issue, because this is what it's going to look like in 10, 20 years.
Yeah. Yeah, well, I think that's really good perspective to be able to give to a parent to, you've experienced it, you've had both with you and your son. And I think that obviously makes you just a much more compassionate provider, because when you've lived through something, you can see it through a totally different light, just like, I have on my end with the Maya with me and with Lily. And I keep looking at Mia, because Mia's my airway kid. And so while Lily would get colds a lot, and she might be my airway kid in that we need to expand her airway, she was pretty okay otherwise. Like, we needed to release that tongue. I keep looking under her lip and going, I think we might need to release that upper lip too, but we'll defer to Dr. T on that when she goes back to see her next. And she's doing amazing in her ALF, and people are actually noticing in pictures I'm posting online, they're going, wow, her face has changed since August. I mean, and she's 4, so it moves so quickly, like, and so cool. But she's now also eating new foods, and every single day we have a star chart that came kind of by accident with a little magnetic calendar I got her when we got stuck at home 2 months ago. And she was like, oh, let's use this. I was like, okay, great. It's like a behavioral chart. So I was like, great. So every night now we go through, like, did we eat our food today? Did we try something new? Did we, follow directions in the morning, in the afternoon, in the evening? And she's like so into it, which is just
Hallie, I need you to come to my house and embrace my children, please. I'm like,
I mean, this was like totally by accident, like unplanned, but probably really good too, because everybody being here like cooped up, with my au pair is the best human in the world, because Lily is like a 4-year-old with massive attitude some days and not sleeping as well as she used to. So now she's also like in our bed, which also impacts her behavior the next day. So anyways, my little tangent there. It's been really cool because with the expansion, she's now willing to try things, and she has better management of the food. And so instead of immediately going, that smells, and like that being enough to just set her off, she's going like, I don't know. And then she's putting it in her mouth because she knows
that's so great.
She can spit it out if she doesn't like it. Nobody's going to force her to eat it. We weren't forcing her before either, but she couldn't manage it before. She couldn't, move it with her tongue, chew it properly. And so the combination of the appliance and Mayo it's just incredible, which is really cool. And then on the flip side, I look at Mia, who was also released, but at day 5, much earlier than Lily. And she was my kid who no one wanted to give her a torticollis, diagnosis, because she was hitting her milestones. They were just always like at the tail end. But she was the kid who dragged her foot behind her when she crawled, and never crawled until like a couple of days after she walked, and was on the, it was already starting to get late, not really late, but late for me. It was like 13 months. So we went to Dr. Steele and Dr. Coop. We took her to the osteopaths, and what do you know, like 2-3 days later, she gets up and she starts walking. And then couple days after that, she crawled, and I was like beside myself. I was like, oh, she's crawling. And my husband's like, but she already walks. Like, what does it matter? I'm like, no, you don't get it. Like, it matters on so many developmental levels, because this is my kiddo who like had torticollis and was dragging her leg, and things weren't integrating. And this just everything, like you talked about, it's like that zipper. It starts up here and goes all the way down the body.
How lucky are your kids to have you as a mother? I mean, how, seriously though, it would be, you can't know, but like, it would be very cool to have it. I mean, I have no doubt her life will be very different for the better.
Well, and the interesting thing about Mia is she's my croup kid and my RSV kid, and my kid who landed us in the ER twice last year, like within like a month, because of her airway stuff. And I keep thinking like, maybe we should like take an x-ray of her. Maybe we should do a scan on her and see like what her airway actually looks like, to see if we should be concerned. Just knowing how the palate forms when they're in, but even at 2, she's got a really good lingual palatal suction. Her mouth is closed. She's not a mouth breather. So I'm kind of like riding that wave. But now, even with the interesting thing to me is that even with being home, right after we started with being home, she was put on an antibiotic for what seemed to be moving towards croup. She was getting that croupy cough at night. And I'm like, oh, here we go. Like, she's had this 4 times in her life already at the age of 2. So we put her on antibiotics. I'm like, I do not want to go to the emergency room at Suburban right now. So let's just be proactive here. And that seemed to help. And then Lily got something. And so then Lily was on an antibiotic, and then Lily was on a second antibiotic, which didn't work for her. And then we realized it was allergies. So that seemed to knock it out, although no allergy issues since, so I'm not entirely convinced it was allergies, because she's not on any medication. So going back to Mia, 3 days ago, she started again with this coughing, and I've given her some, allergy meds. I'm not a mom who loves to just like slap on the meds, but I'm like, right now, let me see what I can do to like treat the airway and keep us out of the ER.
Yeah, the last thing you want is a kid that's coughing, because like I've been taking allergy meds, and I never take them because people look at me and run out of the room, and I'm like, oh.
Yeah, and so she's got this cough, and it's mostly now at night or first thing in the morning, and I'm like, let me try the allergy meds first. That's probably the least invasive thing we can do before putting her on like, an antibiotic again. It's not helping. So I'm like, wait, I'm like, we're going to go text the doctor when we get off the recording and be like, hey, we're headed back towards croup again, which is so interesting to me because she hasn't left our house. She hasn't been out of the house. And this is where I start to wonder, like, is she going to be my kid who's kind of on that path to asthma, which a lot of those croupy kids turn into, despite the fact that she really has not been exposed to new germs in the past 2 months being quarantined in our house. So I don't know. It's a little situation, but I kind of want to get her scanned now and take a look at like why this keeps happening. figure out what the root of the issue is so we can stop medicating her. But
I know my daughter was born with asthma. That's a whole different.
Yeah. So, but you look at these kiddos with these airway issues and, it's like, I want to like reintegrate my family back into the world, obviously once the stay-at-home order lifts, but then I look at Mia and I go, is that safe? Can I really do that for her? Because I don't want her back in suburban ER on 8 hours of fluids and, because then she starts to get dehydrated and it's a whole kit and caboodle. So fun times, kids, they keep us on our toes.
Oh, for sure. I'm glad mine are older now. I've done my time. But different problems, maybe bigger problems. Cars and lots of strong opinions. So.
Well, this has been amazing, Kim. Is there anything else that you want to add that we haven't covered? I mean, I know we talked about, what you do in your practice, your own personal experience with you and your kiddos, as well as tongue-tie release across the ages and COVID-19. Anything else we haven't touched on?
No, I mean, there's a million things I'd love to talk to you about, but no, I think, I think that what you're doing is great. And I think it's going to become, people, it's just going to be, I think it's just going to become like part of the whole, you go to the dentist, you go to the Maya. I think it, every kid should be screened. I think. What's the downside? There's no downside. Like, what's the downside to doing that frenectomy or doing that expansion? There's no downside. Really, there's no downside. So,
I'm actually creating a quick myo screener that I've got a little friend joining us here in the back. A quick myo screener that, we can even send to you and you can give them to your hygienist. And when they're doing,
that's awesome. That's awesome.
Like a 1-page little checklist. And so when they're doing a routine dental visit, they can kind of just go through that checklist in their brain or even have it there to check off while they're waiting for you to come in and see the patient. Because I think that, obviously it can be very costly to add myo in. And I think that's the biggest objection that anybody has is it's another thing. It's another time investment and money investment. But if we can really.
But what's it saving?
Exactly. That's exactly it.
Yeah.
How much does it save you in the long run, health-wise, money-wise, time-wise, if we address the issue now? Like, where will you be a year from now, 2 years from now, 5 years from now, if you don't address this issue? And so I think that, the earlier we can identify it, the less intervention we usually need. I say less intervention, meaning we may need to do fewer things with kids than we might need to do with an adult who has all these other issues going on and all these other specialists involved. That doesn't hold true for every case, but, it is interesting to see how many of the check boxes are checked off with my adults versus my infants or my toddlers who I'm going, ooh, I know in the future those other 15, 20, 30, 40 things, because there's 50 check boxes on my screener, or 40, I think. We have like 40 check boxes on the screener. And a lot of my adults have them all checked off, which is crazy. So we'll definitely send that your way, and that'll actually we'll be launching that like in a week. But the goal is just to get them in as fast as, as early as we can, like you said, so we can deal with the issue as
before there's a chronic problem. Yeah. I mean, then you're treating the problem and the root of the problem.
Right. And hopefully preventing future problems as well. Yeah. Awesome. Well, thank you, Kim.
Thank you, Hallie.
Fun. I'll see you guys soon in the office.
All right. Take care. Thanks. All right. Bye.
Bye.
Thanks for listening to this podcast. If you want to hear more of these Myo, Tots, Airway, and feeding related episodes, be sure to leave a review on Apple Podcasts or pledge a small amount on patreon.com/the Untethered Podcast. If you found value, others in this space will too. So be sure to share this episode on your social media platforms and join us over on Facebook, on my Facebook page at Hallie Bulkin Biz, on Instagram at Hallie Bulkin, and you can head over to theuntetheredpodcast.com to grab a copy of the show notes, where you can also subscribe to be kept up to date on the latest podcast episodes.